keynote address from our Dr. Pazouki. So we are kindly requested to come to the dais and give you a keynote address.
Thank you. In the name of God, at first I should thank the organizing committee which helped us to help our patients and for inviting me to this honorable Congress. My speak is about, would you please go to the next slide, thank you. Who was a young Afghan pregnant woman, and she was in the 3rd trimester. You know, for the 1st and 2nd trimester we have less problem. And she had biliary pancreatitis. Fortunately, her pancreatitis was mild. And you know, it is recommended to do cholecystectomy at the same admission. But we didn't know what to do for her. We searched the web, and there wasn't any guideline and any documented research about such patients. And we didn't know to do the cholecystectomy for her at the same admission or to stay and do after the pregnancy and childbearing. And if we want to do, what to do, open or laparoscopy. And fortunately, at present, we have the guideline of SAGES for treatment and use of laparoscopy for surgical problems during pregnancy. About that patient, we discussed the problem with her husband, and we told about the risk of doing operation, and he didn't accept it to be operated. And after about 3 weeks later, she became again with another pancreatitis. And at that time, when she was 8 months, we did lap poly for her in 2000. 6 years ago, we did our first trimester, late trimester lap poly for the patient. And now these guidelines rate the evidence, rate the recommendation, and based on existing data and consensus of expert opinion. You know the level of evidence. Level 1 is properly conducted randomized controlled trials. And level 2 is controlled trials without randomization or cohort or case control studies and multiple case series. And level 3 is descriptive case series and expert opinion. And a scale for evidence grading is grade A is high level, level 1 and 2 well performed studies with uniform interpretation and conclusions by expert panel. Grade B is high-level, well-performed studies with varying interpretation and conclusion by expert panel, and grade C is lower level evidence 2 or 3 with inconsistent findings or varying interpretation or conclusion by expert panels. The incidence, about the incidence, we have 1 in 500 to 635 women will require non-obstetrical abdominal surgery during their pregnancies. And the most common non-obstetrical surgical emergency complicating pregnancy are acute appendicitis, cholecystitis, and intestinal obstruction. And about the trimester of pregnancy, we know that in the 2nd trimester it's safe to do the best trimester for operation. But fortunately, laparoscopy can be safely performed during any trimester of pregnancy, and its level is moderate and a strong recommendation. And we had during past 3 years, during past 6 years, many laparoscopic cholecystectomy and appendectomy, and even splenectomy in pregnant women. Long-term effects to the children, there isn't any side effect to the children. Even in different studies, it has been shown that there is no side effect. About diagnostic laparoscopy, while not enough data are available to recommend this as a primary diagnostic approach in pregnant patients, it is a reasonable alternative to radiologic imaging, and it has very low risk. About the acute abdomen, laparoscopic treatment of acute abdominal disease has the same indications in pregnant and non-pregnant patients, and we don't differ between our patients, and our management is the same for pregnant women. About laparotomy or laparoscopy, it depends on the skill of surgeon. It should be well-trained laparoscopic surgeon to do laparoscopic surgery, and also availability of appropriate staff and suitable equipment is needed. Advantage of laparoscopy in the pregnant patient is the decreased fetal respiratory depression due to diminished post-operative narcotic usage, low risk of wound complication, diminished post-operative maternal hypoventilation, less uterine manipulation, shorter hospital stay, and decreased risk of thromboembolic events are proven for laparoscopy. About the patient positioning, fortunately, as usual, we use the good position for lap chole, but for other procedures, if we want to operate the gravid patient, they should be placed in left lateral decubitus position to minimize compression of the vena cava. And for initial port placement, although there isn't any proven side effect of all three types, Hassan or open, Verus needle or optical trocar, but in our experience we used for all of them open technique, and we didn't have any complication. If the location is adjusted according to fundal height and previous incision. Also, if the site of initial abdominal access is adjusted according to fundal height and the abdominal wall is elevated during insertion, both the Hassan technique and Verus needle can be safely and effectively used. Trocar placement be altered from the standard configuration to account for the increased size of the uterus. Ultrasound guided trocar placement also has been described, but it hasn't been in a randomized, in a prospective trial, but some case reports. About the insufflation pressure, adverse consequences from CO2 insufflation is a debate for laparoscopy, and some persons recommended gasless laparoscopy, but it has been proven that if we have less pressure, will be more decreased because we have residual lung volume is decreased and functional residual capacity is decreased. So we use mostly about 8 millimeter Hg for our pregnant patients, but less than 12 is acceptable. And some animal studies have confirmed that fetal acidosis with associated tachycardia, hypertension, and hypercapnia during CO2 pneumoperitoneum, but other animal studies contradicate these findings, and there is less fear about using CO2. Insufflation pressure, there are no data showing detrimental effects to human fetus from CO2 pneumoperitoneum. CO2 insufflation of 10 to less than 12, I should mention less than 12, Hg millimeter can be safely used for laparoscopy in pregnant patients. And as I told previously, we used mostly 8 millimeter Hg. About CO2 monitoring during the operation, fetal acidosis and associated fetal instability in CO2 pneumoperitoneum and long-term effects of CO2 are being studied. And the human fetus also, we didn't have any proven not to use CO2. And maternal blood gas monitoring of arterial carbon dioxide is under the investigation, and also end-tidal carbon dioxide monitoring. But less invasive capnography that we have in all of our patients has been demonstrated to adequately reflect maternal acid-base status in humans. About VTE, thromboembolic prophylaxis, you know, pregnancy is a hypercoagulable state with about 0.1 to 0.2%, and you know, no peritoneum and position of patient make more vulnerable to VTE the patient. Some research used unfractionated or low molecular weight heparin for the patients, but intraoperative and postoperative pneumatic compression devices and elastic stockings are completely safe. And among our recent cases, we don't use heparin, and because the time of operation is very low and less than most of our operation is less than 1 hour. And early post-op ambulation are highly recommended, and we use these guidelines for our patients, not heparin. Which procedures are done during cholecystectomy, choledocholitis, ERCP with sphincterotomy, laparoscopic CVD exploration, appendectomy, adrenolectomy, and nephrectomy and splenectomy. About adnexal masses, incidence of adnexal mass during pregnancy is about 2%. Most of these adnexal masses discovered during the first trimester and are functional cysts that resolve spontaneously by the second trimester. And laparoscopy is safe and effective treatment in gravid patients with symptomatic ovarian cyst masses. And about torsion, 10 to 15% of these masses undergo torsion, and laparoscopy is recommended, highly recommended, because of its benefits for both diagnosis and treatment of adnexal torsion, unless clinical severity warrants laparotomy. Perioperative care, fetal heart monitoring should occur preoperatively and post-op in the setting of urgent abdominal surgery. Obstetrical consultation is mandatory, but sometimes we have emergent patients that if the consultation wasn't done before the surgery, we should do it post-operatively, both based on the severity of the patient's disease, gestational age, and availability of consultant. About tocolytics, previously we used progesterone treatment because fear of preterm labor, but no literature supports the use of prophylactic tocolytics, and in the last patient I operated was 29 to 30 months according to sonographic age, and I did for her when she came with symptomatic gallstones, and sonography showed multiple stones, small and teeny stones. Without any delay, I did for her lap poly, and fortunately